Hello, and welcome to this weekly pelvic perineal literature watch for June 19th, 2026, presented by Erwan Leroumeur, physiotherapist in Paris. This is scientific information only, not individualized medical advice. References are available in the description. This week, the watch reviewed 66 articles. The main thread will be endometriosis, pelvic pain, and sexual function. The starting point is an important paper for physiotherapists. A systematic review with meta-analysis published in the Brazilian Journal of Physical Therapy on the effectiveness of physiotherapy techniques for symptoms related to endometriosis. We will then discuss genito-pelvic pain, hypermobility, dyspareunia, postpartum sexual health, urinary leakage during sexual activity, and a few important papers on pessaries, pelvic floor disorder prevention, perineal trauma after childbirth, and continence. The practical question behind this episode is straightforward. What can we actually say today about physical approaches in endometriosis and pelvic pain? Where is the evidence becoming clinically useful? And where should we still remain cautious? First section, top story, the key paper of the week. Mena-González, Leiros Rodrigues, and Hernandez Lucas, published in the Brazilian Journal of Physical Therapy, a systematic review with meta-analysis on the effectiveness of physiotherapy techniques and methods for endometriosis-related symptoms. The authors included quantitative studies exclusively involving women with endometriosis and interventions that included some form of physiotherapy technique. The approaches were diverse: manual therapy, education, electrotherapy, exercise, relaxation techniques, and acupuncture. The results showed significant reductions in dyspareunia and pelvic pain, as well as a significant improvement in quality of life. The certainty of evidence was rated as moderate. This matters because the field often sits between strong clinical expectations, small trials, heterogeneous protocols, and outcomes that are not always easy to compare. The authors concluded that several approaches appear effective in improving chronic pelvic pain, dyspareunia, dysmenorrhea, non-menstrual pain, quality of life domains, mental and physical health, and functional well-being. This paper does not say that one single technique treats endometriosis. It does not say that every patient should receive the same protocol, but it does mark a useful shift. Physiotherapy is no longer just a loosely defined adjunct. It is becoming a set of testable interventions with pain, function, and quality of life outcomes. For practice, the message is twofold. First, there is now a favorable signal for physical interventions in endometriosis. Second, that signal is composite. The studies do not all test the same thing. Massage and perineal stretching, electrotherapy, exercise, education, relaxation, and acupuncture do not rely on the same mechanisms, nor do they have the same indications. So this is a good paper to support clinical discussion, but not to sell a ready-made recipe. The question becomes, in this specific patient, which symptom dominates? Menstrual pain, deep pain, introital dyspareunia, pelvic floor hypertonia, fatigue, activity avoidance, sensitization, associated digestive or urinary symptoms. Physical treatment should start from that map, not from the diagnosis of endometriosis alone. Second important paper, genito-pelvic pain in hypermobile patients. Barton L et al. Published in Rheumatology International a cross-sectional study on women with hypermobile Ehlers-Danlos syndrome or hypermobility spectrum disorder and genito-pelvic pain. The authors reported a high presence of provoked vestibulodynia in this specialized population. Among patients with provoked vestibulodynia, some had posterior vestibular allodynia, compatible with a contribution from pelvic floor hypertonia. Others had more diffuse vestibular pain, suggesting different possible mechanisms: inflammatory, neuroproliferative, hormonal, or mixed. For physiotherapists, the value of this paper is that it reminds us that sexual pain is not a single clinical entity. Two patients may use the same words, burning, penetration pain, dyspareunia, and have very different profiles. In a hypermobile patient, one may encounter musculoskeletal instability, myofascial pain, vestibular hypersensitivity, autonomic symptoms, high fatigue, and sometimes associated bowel or bladder symptoms. This does not mean that everything comes from the pelvic floor, but it does justify a precise assessment of tone, provoked pain, protective strategies, hips, pelvis, and load tolerance. This paper is cross-sectional and does not prove causality, but it has clear clinical value. It helps avoid shortcuts. Vestibulodynia in a hypermobile patient is not automatically psychological, not automatically muscular, and not automatically hormonal. Assessment should keep several hypotheses open. Third axis, female sexuality, pain and pelvic function. Pope, Marino, Myers et al. Published in Obstetrics and Gynecology a review on female orgasmic disorder. At first glance, this topic may seem distant from endometriosis, but it belongs to the same clinical landscape. Sexual health depends on neurobiological, vascular, hormonal, psychosocial, anatomical, and pelvic floor factors. The authors remind us that female orgasmic disorder affects approximately 10 to 28% of women and remains insufficiently addressed in clinical practice. Assessment should include sexual history, relationship factors, medication use, physical examination, clitoral anatomy, and pelvic floor function. For pelvic perineal clinicians, the point is not to reduce sexual health to pain or penetration. A patient may have endometriosis, dyspareunia, hypertonia, reduced desire, arousal difficulties, or orgasmic difficulties. Not all of this belongs to physiotherapy, but the pelvic floor may be part of the picture, especially when pain, anticipation of pain, or protective contraction modifies sexual response. Again, the paper does not offer a simple solution. It mainly reminds us that sexual symptoms need precise words. Pain, desire, arousal, lubrication, orgasm, satisfaction, and avoidance do not describe the same clinical issue. Clarke published in the British Journal of Nursing a review on coital urinary incontinence. This symptom is often underreported, although it can directly affect confidence, sexual activity, and intimate relationships. In women, leakage may occur at penetration, during intercourse, or at orgasm, and may be linked to stress, urgency, or mixed urinary incontinence, and to pelvic floor dysfunction. In men, coital incontinence is often discussed after prostate surgery, particularly after prostate cancer treatment. This article is useful because it connects continence and sexuality instead of treating them as separate files. Patients do not always spontaneously mention this symptom. When present, it can change sexual behavior, create avoidance, or combine with pre-existing pelvic pain. For physiotherapists, the practical point is to include the question in a simple and non-intrusive way, especially in patients already followed for incontinence, prostatectomy, pelvic pain, or postpartum recovery. Postpartum, sexuality, pain, and recovery. Capozzi, Maglietta, Monfardini, et al. Published in the American Journal of Obstetrics and Gynecology, MFM, a prospective longitudinal study on sexual well-being before and after childbirth, using the Female Sexual Function Index. 197 women were included. Among women who were sexually active in late pregnancy, the total sexual function score decreased significantly at 6 months postpartum. Caesarean section was independently associated with higher postpartum scores, while major perineal trauma showed an unfavorable trend. The arousal domain strongly correlated with overall sexual function, both before and after childbirth. This paper is useful because it measures sexuality before and after birth using a validated tool. It also highlights a limitation. Standard questionnaires such as the FSFI may be less suitable for women who are not sexually active, which is common during some postpartum periods. In other words, not having resumed intercourse is not just missing data. It is already clinically meaningful information. Walker, Codispoti, Weichert et al. Published in Sexual Health, a survey on sexual health counseling during postpartum visits. In their sample, 91% of participants reported receiving some form of sexual health counseling, but only about half found it helpful. Providers were more likely to discuss sexual health with primiparous patients, with patients who had not resumed intercourse, and conversations were longer after vaginal birth than after cesarean delivery. This paper is interesting because it shows that simply mentioning the topic may not be enough. Information can be provided, yet still be too general, too brief, or not adapted to the patient's actual situation. For an episode on endometriosis and pelvic pain, this echoes a simple idea. The quality of information matters as much as its presence. A patient with pain does not only need to hear that sexuality can be affected, she needs to understand which symptoms to monitor, when to seek help, and which options exist. Özdemir, Filolu, and Yeşil published in Scientific Reports a study on pelvic floor disorders, body image, and sexual desire during the third trimester of pregnancy. The authors found relationships between pelvic floor dysfunction, more negative sexual attitudes, and sexual desire. The paper is cross-sectional, but it adds to the theme. Sexuality during pregnancy is not only about hormones or the couple. The body, pelvic symptoms, body image, and sexual representations interact. At this point in the episode, a clear thread emerges. Endometriosis, pain, hypermobility, postpartum recovery, and coital incontinence are different situations, but they all require detailed assessment. Not to make everything more complicated. To avoid treating different symptoms with the same standard sentence. Tools, prevention, and conservative care. Perusa, Martinez, Sivak et al. Published in International Urogynecology Journal, a scoping review on public health programs aimed at preventing pelvic floor disorders. The authors found no large-scale publicly funded programs. The available studies were mostly small, often focused on urinary incontinence, while pelvic organ prolapse, fecal incontinence, dyspareunia, and chronic pelvic pain were underrepresented. The most promising programs often combine pelvic floor muscle training with both in-person and virtual components. Reported barriers were very practical: lack of time, lack of knowledge, stigma, funding difficulties, patient recruitment, and staffing. This article is useful for placing endometriosis and pelvic pain within a broader landscape. Prevention and education are frequently discussed, but truly funded, evaluated, accessible, and reproducible programs remain rare. The issue is not only whether an intervention works in a trial, it is also whether it can be delivered in real life. Several pessary-related articles also stand out this week. Yinli and Zhou published in International Urogynecology Journal a secondary analysis of a randomized controlled trial on vaginal epithelium-related adverse events in pessary users. Among 411 women followed, 29% developed an event: erythema, abrasion, erosion, bleeding, or excessive discharge. Associated factors included time since menopause, advanced prolapse stage, and other variables. Continuous estrogen use for at least 12 months appeared protective. Hong, Sham, Zhang et al. Published in Obstetrics and Gynecology a case series on patient-specific pessaries in individuals who had unsuccessful or suboptimal outcomes with standard pessaries. Among 113 patients, 63.7% retained and continued to use their patient-specific pessary at final follow-up. This is a retrospective series, but it suggests an interesting direction. After failure of a standard pessary, the question may not simply be pessary or no pessary, but fit, design, comfort, and tolerance. These papers are not about endometriosis, but they are relevant to pelvic perineal practice. Conservative devices require follow-up, adjustment, and attention to adverse events. Non-surgical care is not automatically simple care. Childbirth, perineum, and pain? Useful signals. Goldman, Hedstrom, Epstein, and Bergman published in Acta Obstetricia et Gynecologica Scandinavica a case control study on risk factors for deep perineal wound dehiscence after second-degree tears or episiotomy. The cases were 105 women with deep wound dehiscence within 2 weeks postpartum, compared with 210 controls. After adjustment, episiotomy increased the risk of deep wound dehiscence, while intrapartum antibiotics appeared protective. De Castro, Viana, Botelho, and Marino published in International Urogynecology Journal a double-blind randomized trial on photobiomodulation after first or second-degree perineal lacerations or episiotomy. 59 women were included. Both groups improved, but between-group analysis did not show clinical improvement in pain or healing with photobiomodulation. The intervention group used fewer analgesics, but the main conclusion remains negative for pain and healing. Ari, Taylan Ari, Karaman, and Akdemir published, in the same journal, a randomized trial on standardized mediolateral episiotomy using a blade-based device compared with conventional scissors. 60 nulliparous women were included. At 6 months, persistent perineal pain was less frequent in the device group, and sexual function scores were higher, mainly in pain-related domains. These 3 studies should not be blended too quickly. One is observational, one is a negative trial on photobiomodulation, and one is a positive trial on standardized incision technique. Together, they mainly show that technical details in obstetric perineal care still have functional consequences: healing, persistent pain, sexuality, and satisfaction. Continence, treatments, stimulation, and patient selection. Yazdi, Nazari Moghadam, Soleimani et al. Published in BMC Urology, a randomized trial comparing transcutaneous tibial nerve stimulation with solifenacin in women with overactive bladder. 118 patients were included. Both treatments improved symptoms, incontinence, and quality of life. Tibial stimulation produced slightly greater improvement in symptom severity and incontinence, with a much better tolerability profile. Adverse effects were reported in 88.1% of solifenacin users, while none were reported in the stimulation group. Huckbelen and Ince published in International Urogynecology Journal a randomized trial on comfort theory-based nursing interventions in women with stress urinary incontinence. The program included pelvic floor-focused yoga, breathing, and meditation. 40 women were included. The intervention group improved incontinence severity, quality of life, and comfort. The sample is small, but the paper is interesting as an example of a structured, low-cost, non-pharmacological intervention. Collado, Rissell, Romero et al. Published in Neurology and Urodynamics a prospective multi-center 10-year follow-up of Advance and Advance XP male slings after prostatectomy. Among 87 patients with complete follow-up, the results suggest acceptable long-term continence rates, especially in ideal candidates, mild to moderate incontinence, no previous pelvic irradiation, and no prior surgery for incontinence or urethral stricture disease. Again, patient selection appears decisive. Last section, the briefs. First brief, Ansari, Pine, Sapkalova et al. In Neurology and Urodynamics described urinary symptoms and urodynamic findings in patients with hypermobile Ehlers-Danlos syndrome. Urinary symptoms were common, but the authors did not find strong evidence for intrinsic bladder pathology. Findings pointed more toward pelvic floor and neurologic contributors. This is consistent with Barton et al.'s paper on genito-pelvic pain and hypermobility. Second brief, Rothstein, Rose, Stark, and Engberg in Acta Obstetricia et Gynecologica Scandinavica assessed three-dimensional endoanal ultrasound measurements of the perineal body in 148 nulligravid women. Measurements were reproducible, especially for perineal body length and area. This is a methodological paper, but useful for future research on functional perineal anatomy. Third brief, Kovalenko, Zamagni, Voloyhaug et al. In Acta Obstetricia et Gynecologica Scandinavica assessed inter- and intra-observer agreement for two-dimensional and three-dimensional transperineal ultrasound measurements of the levator hiatus during the second stage of labor. Agreement was generally good, particularly for some measurements. Again, this is not a treatment paper, but it supports the development of more standardized assessment tools. Fourth brief, Chai, Ryan, Naik et al. In Neurology and Urodynamics analyzed more than 16,000 adults from NHANES. Intentional weight loss was associated with lower frequency of urinary incontinence symptoms compared with unintentional weight loss. Exercise was associated with the lowest prevalence of frequent symptoms. This is observational, but the sample is large. Fifth brief, Herolin, Knowles, Doherty et al. In Neurology and Urodynamics published a pilot study of implanted adaptive pudendal nerve stimulation in 13 women with refractory urinary incontinence. The technique appeared feasible and safe at 6 months, with a favorable clinical signal. Promising, but still very preliminary. Conclusion. This week, the paper by Mena-González et al. Provides a strong basis for the main theme. In endometriosis, several physiotherapy approaches are associated with improvements in pain, dyspareunia, and quality of life, with moderate certainty of evidence. Around this paper, the watch broadens the picture. Barton et al. Remind us that genito-pelvic pain in hypermobile patients may involve different mechanisms. Pope and Clarke bring sexual health into sharper clinical focus: orgasm, pain, coital incontinence, pelvic floor function, relationship factors, and associated symptoms. Capozzi and Walker show that the postpartum period remains a time when sexual function should be measured, not just briefly mentioned. The practical message is intentionally simple. Endometriosis and pelvic pain are not reducible to one lesion, one muscle, or one technique, but physical interventions become more credible when they are linked to a symptom, a likely mechanism, and a follow-up criterion. Thank you for listening. Always check the full papers and current guidelines before changing practice. References are available in the description, and see you next week for another edition.